Hi everyone, welcome to the second part of the video. In this video, I would like to cover the remaining two injectable agents, namely the GLP1 receptor agonist and amylin analog. I would also like to enlighten you on a few counseling points where you can offer to patients if patient is treated with insulin and also other injectable agents. Coming to incretin mimetics, we have actually discussed this in the second part of the module, while we are talking about DPP4 inhibitors. Now, the glucagon-like peptide 1 receptor agonist, or GLP1RA, is basically the injectable incretin mimetics. Just a quick recap, the incretin hormones is basically the intestinal peptide hormones, whereby they are released in response to the glucose and lipids from the nutrients or food that we have taken. So examples like glucagon-like peptide 1 and glucose-dependent insulinotropic polypeptide are the incretin hormones found in our body. The functions of these incretin hormones are to stimulate postprandial insulin release, promote the uptake of glucose by muscle and adipose tissue, inhibit glucagon secretion, delay gastric emptying, and promote satiety. So the currently GLP-1 receptor agonists that are available in the market can broadly divided into whether we are giving them into daily dosing or weekly dosing. So for example, exenatide immediate release is actually given as twice daily, administered subcutaneous within 30 minutes before main meals. The liraglutide is given once daily and it can be administered anytime with or without meal. The lisinopride is actually available together as a combination formulations with insulin glargine, and it is administered once daily. Also, it must be administered 60 minutes before any meal time. While the weekly dosing include the exenatide extended release versions, which they can be given as weekly, once weekly, and it is administered anytime with or without meals. Similarly, dulaglutide and semaglutide also given once daily, and they can be given at any time with or without meals. So the main mechanism of actions of GLP-1RA is that they act like the analogues of glucagon-like peptide, the intestinal incretin hormones in our body. They are the GLP-1 agonists, so they can promote or stimulate postprandial insulin release, reduce glucagon secretion, delay gastric emptying, and because of the functions in delaying gastric emptying and promote satiety, it has been shown to be helpful in reduced weight gain. And the weight reductions can range between 1 to 4.1 kg. So recently, GLP-1 receptor agonists also found to actually have some beneficial effect in promoting beta cell proliferations. The GLP-1RA is indicated to treat type 2 diabetes. And several important notes which I would like to highlight here is that the GLP-1RA can be used with oral glucose lowering drugs and or with insulin. The GLP-1RA is given by subcutaneous, and it is often mistaken as insulin. So we must take note that the GLP-1RA is not a substitute for insulin. The GLP-1RA should not be used together with DPP4 inhibitor because they are from the same class of drug. So this agent is actually injectable and administered by subcutaneous, similar to insulin preparations. The common side effects of GLP-1 receptor agonists include nausea, vomiting, diarrhea, mostly GI side effects, and as well as pancreatitis. The GLP-1 is actually contraindicated in patients with history of pancreatitis or any thyroid cancer. The exenatide and lisinopride are not indicated for patients who suffer from gastroparesis. The last injectable agent is what we know as amylin analog. Amylin is basically a pancreatic hormone that's co-secreted with insulin. It functions to reduce the rate of rise of blood glucose after a meal by delay the gastric emptying, inhibit glucagon secretions, and also reduce appetite. The synthetic human insulin is known as pramlintide. This agent, however, is not available in Malaysia. and is actually indicated to treat both type 1 and type 2 diabetes together with insulin. Although insulin and pramlintide given together may increase the risk of hypoglycemia, this should be informed to the patients, and patients must be well educated on how to manage hypoglycemia, which I will talk a bit more on hypoglycemia management in the subsequent slides. The pramlintide, similarly to insulin injection and also GLP1 RA, is actually given by subcutaneous at meal times. The common side effects of Amylin analog include, again, mostly GI side effects like nausea, vomiting, anorexia, as well as headache. So having gone through all the injectable agents, now we move into the second sections where I would like to highlight a few counseling points which we need to provide to patients when patients is treated with insulin or injectable agent. First, the common injection sites for insulin and also other injectable agents include abdomen, the arms, the thighs, and also the upper area of the buttock. However, it is important for us to note that the insulin absorption has been shown to be rapid, the fastest and better absorptions at the abdomen, followed by arms, thighs, and lastly the buttock. So we often advise patients to inject bolus insulin or the mealtime insulin, either the rapid acting or the short acting one, into the abdomen. Patients can consider inject the long acting insulin into arms, thigh, or buttock. It is important to advise the patients to inject the insulin or other injectable agent at different spots within the recommended parts of the body. This is basically to avoid hard lumps and fat deposits, namely the lipodystrophy effect reactions at the area of injections. So if patient is injecting the preparation at the abdomen, we always advise them to picture the abdomen as of a clock. So whereby each injections, you follow either clockwise or anti-clockwise, at least 2 inches or 2 cm away from the previous injection site. Patients is also advised to keep at least 2 inches away from the radius around the navel. So there are some important points about the injection techniques which I would like to highlight here. First, check the expiry and the appearance of the preparations. Make sure there is no lumps or funny appearance of the preparations. For new pen, it is always advised to prime the device by dialing at least 2 units of the preparations, and patients should be able to see a droplets of the preparation appear at the needle. Inject at 90 degrees. After injecting, hold the device for 10 seconds before removing the insulin pen. Rotate the sites of injection. Maintain at least 2 cm distance from the injection site. And patients are always advised to not reuse their needle. Just a quick recap again, whereby for rapid-acting insulin, it is always advised to inject either 15 minutes before a meal or immediately before a meal. For storage of the insulin, unused insulins are always stored in the fridge, not freezer, and it can be stored up to the expiry date as stated on the medicine box. The currently in use pen can be stored at the room temperature. This applies to insulin preparation. So after the pen is open, it can be used, it can be stable within 28 days only. So after 28 days, we always advise patients to discard that. So for patients with diabetes mellitus, self-monitoring is crucial. So why is it? The self-monitoring blood glucose basically help patients to build an individualized blood glucose profile. It also helps the doctor to adjust medicines therapy more accurately. It can help the patient to evaluate the impact of the diet, exercises, and medications on their blood sugar level. And patients are able to assess whether their blood glucose targets levels had achieved or not. And it also helps patients to recognize the high and low blood sugar level. So how frequent patients should self-monitor their blood glucose? That depends on what type of treatment patient is receiving. If the patient is on lifestyle modification or diet only, It is always advised that patients perform SMBG, self-monitoring blood glucose, before after breakfast, after lunch, or after dinner, or during mealtime. That is also similarly for patients who are on oral glucose lowering drugs. For insulin, all the times, as you can see here. So next we come to hypoglycemia. Hypoglycemia is defined as when the blood sugar level is less than 3.9 millimole per liter. It is important that we educate the patients on the common signs and symptoms of hypoglycemia. Include feeling hungry, weakness, lack of concentrations, hand shaking, palpitations, sweating, and even if the sugars go down to, for example, less than 2.5, patient may faint or unconscious, where it requires emergency hospitalization. So how do we educate the patients on hypoglycemia management? So we usually advise patients to treat the blood sugar using the 15-15 rule. First, patient will need to check and record their blood glucose level. If the sugar is less than 3.9 millimole per liter, patient is advised to take 15 grams of carbohydrates, which is a carbohydrate choice. So wait for 15 minutes, then check the sugar again. If it is more than 4 millimole per liter, the hypoglycemia is resolved. Patient is advised to take 15 grams of complex carbohydrate or can proceed to usual meal time. So what are the examples of 15 gram carbohydrates or 1 cup choice? So patients may take 120 ml of fruit juice, half can of Coca-Cola, normal Coca-Cola, not Coca-Cola Zero, 7 or 8 soft candies, and also either a teaspoonful of sugar where they can dissolve in water and then drink that. So for additional information on counseling for insulin therapy and injection techniques, you are recommended to read on these guidelines provided over here and also within the modules on additional materials. So you may find these guidelines over there. Thank you for being here today, and I'll see you in the part 4 of the module on summary points for drugs in the management of diabetes mellitus.